Hello and welcome. Today we're diving into a common yet concerning urinary system issue: bladder catheter-associated infections, or CUTs. These infections occur in the bladder when a urinary catheter, a tube inserted to drain urine, is in place. CUs are a significant healthcare challenge, increasing patient discomfort, treatment costs, and potentially leading to serious complications. Understanding their causes, symptoms, and prevention is crucial for both medical professionals and those who might require catheterization. So, what causes a CUI? The primary culprit is the introduction of bacteria into the urinary tract via the catheter. This can happen during catheter insertion, during the catheter's dwell time, or even during catheter care. Bacteria can enter the urinary tract directly through the catheter, or they can form a biofilm on the catheter surface. Common bacteria involved include Escherichia coli, Klebsiella pneumonia, Pseudomonas aeruginosa, and Enterococcus species. Factors that increase the risk of infection include prolonged catheterization, improper insertion or maintenance techniques, and compromised immune systems. Now, let's look at the pathophysiology: what happens in the body. When bacteria enter the bladder through the catheter, they can adhere to the bladder wall and multiply. The body's immune system responds, leading to inflammation. The presence of a foreign object like the catheter hinders the body's natural defenses, making it difficult to clear the infection. A biofilm, a community of bacteria encased in a protective matrix, can form on the catheter surface, further shielding the bacteria from antibiotics and the immune system. This biofilm can act as a reservoir for infection, leading to recurrent or persistent CUTs. CUTs are one of the most common types of healthcare-associated infections. They account for a significant percentage of infections acquired in hospitals, long-term care facilities, and even at home. Millions of people undergo urinary catheterization each year, and a substantial portion develop CUTs. The prevalence of CUTs varies depending on factors such as the setting of care, the duration of catheterization, and patient characteristics. Understanding the epidemiology helps inform infection control strategies and target prevention efforts to high-risk populations. How do you know if you have a CUTI? The signs and symptoms can vary. Some people may experience no symptoms at all. These are considered asymptomatic bacteriuria. Others may experience a range of symptoms, including fever, chills, lower abdominal pain, flank pain, urgency or frequency of urination, hematuria, blood in the urine, and changes in mental status, particularly in older adults. It's important to note that these symptoms can also be indicative of other conditions, so proper diagnosis is essential. Diagnosing a CUI requires a combination of clinical assessment and laboratory testing. A urine culture is the primary diagnostic tool. A urine sample is collected, ideally using a septic technique, and sent to the lab to identify any bacteria present and determine their antibiotic sensitivities. A diagnosis of CUI is typically made when a patient with a urinary catheter develops symptoms consistent with a urinary tract infection and has a urine culture that grows a significant number of bacteria. It's important to distinguish between colonization, where bacteria are present without causing symptoms, and a true infection. While there aren't specific types of CUTs in the traditional sense, they can be classified based on their severity, such as uncomplicated versus complicated infections, or based on the specific bacteria causing the infection. Asymptomatic bacteriuria, where bacteria are present in the urine but causing no symptoms, is another important classification that guides treatment decisions. Knowing the specific bacteria causing the infection can also inform the best antibiotic choice. The treatment of CUIs typically involves antibiotics. The specific antibiotic chosen depends on the bacteria identified in the urine culture and their antibiotic sensitivities. The duration of antibiotic therapy varies depending on the severity of the infection. In some cases, catheter removal or replacement may be necessary, especially if the catheter is suspected to be heavily colonized with bacteria. Symptomatic relief, such as pain management, is also an important part of the treatment plan. It is also important to note that asymptomatic bacteriuria should not be treated with antibiotics unless the patient is pregnant or undergoing certain neurologic procedures. Prevention is key to reducing the incidence of CUIs. Several strategies can be implemented. These include avoiding unnecessary catheterization, using proper insertion and maintenance techniques, including sterile technique during insertion, securing the catheter properly to prevent movement and trauma, maintaining a closed drainage system, regularly emptying the drainage bag, and promoting hand hygiene among healthcare providers and patients. Educating healthcare providers and patients about CUI prevention is also crucial. The prognosis for CUIs is generally good with prompt and appropriate treatment. However, cystitis can lead to complications such as bloodstream infections, kidney infections, and prolonged hospital stays. Recent research focuses on developing new technologies to prevent cystitis, such as antimicrobial-coated catheters and improved catheter designs. Studies are also exploring the role of probiotics and other non-antibiotic strategies in preventing cystitis. Ongoing research and innovation are essential to further reduce the burden of cystitis and improve patient outcomes. Thank you for joining us to learn about cystitis. We hope this information has been helpful.